diabetes and the dyslipidemia. I start with a quote from the history Alice in Wonderland. Only a few find the way. This is from Shankar. Some don't recognize it when they do. Some don't ever want to. This is Alice in Lipid Land. Okay. This is what previously, when the guidelines were so confusing, this used to be the scenario. So I shall cover it under the following headings. What is the problem statement? What are the ACC-AHA guidelines and what is the summary behind it? How are they different from the existing ATP3? What are the benefits? And my friend is going to criticize, so I am going to counter him about that. And why are they relevant to us, more relevant to us? We all know this, cardiovascular diseases are number one as far as the mortality risk is concerned, as far as population data is shown. Famous Inter-Heart study shows that lipids as a standalone marker contribute to the maximum risk as far as leading to cardiovascular death, when compared with host of other factors which we all think are important, but lipids have got the maximum risk. And a study which shows that the prevalence of dyslipidemia and diabetics is close to 95 to 97%, be it both males and females. So much so that people have said it is diabetes insipidus rather than mellitus. So we should all put more interest and focus in this. But what do? We are not putting any more focus. Please see this. This is a paper from JAMA which says that people who are above the goal of the risk factor A1C, many of the people are on aggressive therapy. We are always a glucose-centric, but we are not lipid-centric as far as our approach is concerned. Patients who have got LDL above the goal, 60 to 70% have received no treatment. So that is where the problem lies. These are the ATP3 guidelines. All of you are aware about. Less than 100 mostly, less than 70 in some select patients, more than 2 risk factors less than 130, and no 0 to 1 risk factors less than 160. As the ATP has evolved in the last a decade or more than a decade, there is increasing aggressiveness of cholesterol lowering therapy. The 2001 guidelines were modified in 2004 where the additional 70 was added, and in 2008 they felt with the addition of new trials you require to have other data to incorporate and form a new guidelines. So the NHLBI, that is National Heart Lung Institute, constituted the expert panel in 2008, and they had the mandate to review the published literature as to what best as far as managing the dyslipidemia and cardiovascular risk is concerned and come out with guidelines. So these were published in 2013. The mandate before the clinical committee was looking at 3 different clinical scenarios. The first question being, what is the evidence for LDL and non-HDL goal for secondary prevention of atherosclerotic cardiovascular disease? The second question being, what is the evidence for LDL and non-HDL for primary prevention of atherosclerotic cardiovascular disease? And for primary and secondary prevention, what is the impact on lipid levels, effectiveness and safety of specific cholesterol modifying drugs used for lipid management in general and in selected subgroups? These were the 3 important clinical questions based on which the guidelines have evaluated, the committees have evaluated the published data. Unfortunately, for the first clinical question 1 and 2, you didn't have any evidence to suggest that a specific goal is useful or has given a benefit. For 3, there is clinical question 3, there is some benefit. So based on this, the guidelines committee have identified 4 statin benefit groups, which were individuals with clinical atherosclerotic cardiovascular disease, individuals with primary elevation of LDL more than 190, individuals 40 to 75 years of age with diabetes and LDL between 70 to 189, and without clinical cardiovascular disease or diabetes, between 40 to 75 you use a risk calculator and then you assess their risk and then prescribe the statins. This is how you approach the ASCVD. If it's a high intensity, age more less than 75, age more than 75, moderate intensity, LDL primarily more than 190, use high intensity, In diabetics, especially type 1 or type 2, if there is more estimated risk is more than 7.5, use high intensity, otherwise moderate intensity. In the last population, use a risk calculator and then decide accordingly. This is a risk calculator which is most of you must have seen, incorporates the age, race, other risk factors, hypertension, total cholesterol, so on and so forth. The only additions being there is an African American race in addition to this. And you discuss, after assessing the risk, you discuss with the patient, review the potential benefit from the statins, take patient preference into the view and then decide what is the best. The high intensity statin therapy is Atavas 40 or 80 and Rosuva's either 20 or 40, and moderate intensity, these are the drugs in the dosages which have been studied. So the good about guidelines is it recommends a practical approach in reduction of atherosclerotic cardiovascular disease, prioritizes the statin therapy because that is where the maximum evidence is. We are in an era of evidence-based medicine, so evidence says that statins are the most beneficial, patient-centered. And another good thing is shift from coronary artery to atherosclerotic cardiovascular disease. You have included the stroke, you have included the peripheral arterial disease, so it's a good change. Staying out of target because the moment you identify a group, it is easy to treat rather than chase the targets. Limits the vagaries of LDL estimation, and you have cheap drugs, that is statins, with good safety profile. These guidelines are meant to address atherosclerotic risk reduction, not as a management of dyslipidemia. So don't look for other things in this. There are few data which suggest that these clinical guidelines are most useful. Overall, 2013 guidelines are more sensitive to identify patients with CAD than with the other ones. You have another study which is published in the JSCC, again saying the same thing. Patients who have got acute coronary syndrome, again it shows that it is more beneficial, more number of patients are receiving the drug rather than when compared with the 2004 ATP3 guidelines. These implications, 32.4% of eligible patients would benefit from statin. Other non-statin therapies would be reduced because you are not going to have any benefit by giving them as an add-on, and possibly some reduction in the LDL testing is beneficial. So the impact of statins, a paper which was published very recently, 3 days back, high intensity statin therapy is associated with atheroma volume regression from baseline, whereas the low intensity statin and no statin therapy is associated with the atheroma volume progression. So you have to give high intensity statin therapy in patients who have got the indications. There is best scientific evidence. Put some patient preference also and use clinical judgment, but my friend will have different opinion. He is not going to be easily convinced because you cannot convince a believer of anything. For their belief is not based on evidence, but it's a need to believe. So he is going to say that there are no targets for the individuals, but you have targets for all these decades. What is the data which says that how many patients are reaching your targets? Not even half. If you have over CVD, 22% of patients are reaching your targets. We are not different. The abroad also only 50% or less than 50% of patients are reaching the targets. So even if you have targets, you are not going to have any benefit. And statins are not to reduce LDL, statins are to reduce the cardiovascular disease. Targets are not useful. Second issue is there is misconception that there are no targets. We have to assess whether there is reduction of more than 50% or not. So in a way, indirectly we are having the targets in these guidelines. Strong focus on statins. Statins are the ones which have shown the maximum reduction in LDL, and there is no low, it is the lower the better across the trials have shown. So it is even from the most famous Tino 2 also, which has said the lipids lowering contributed to the maximum risk reduction as far as the statins benefit is concerned. Other drugs, there are plenty of drugs available, but you have no benefit as far as in the utilization of clinical benefits concerned. There are no hard endpoints, mortality benefit or risk reduction benefit. Use of others diverts the focus, so you don't get any benefit out of that. So you have less than expected response with others, but you may use them in familial dyslipidemias or maybe when statin is contraindicated otherwise. It exposes more number of people to statins. This paper is going to show you, but I just want to say that apple a day keeps doctor away. There is an interesting study published in BMJ. Statin a day keeps the doctor away. Just see what the study adds. Apple a day or statin a day is equally likely to keep the doctor away. And the story runs further. The extra cost of statin therapy for the drug is estimated to be 180 million pounds when compared with 260 million for apple. It's easy to buy a statin than an apple in the current day world. So don't deny the benefit. Statins are most effective and cheap. Then comes, we are Indians, so we are different. We don't use these many dosages. Prescription practices of Indian statins, Indians who have got coronary artery disease, very poor number. 80 patients per 1000 patients of cardiovascular disease receive statins and only minority receive because access to service, affordability, underdiagnosis and cultural belief. Study published in JAPI which shows that 80 and 40 milligrams, the 80 is more effective than 40. And no patient had elevation of symptoms, no patient had complications.
Dr. Harish, you have 20 seconds more.
So we have clinical inertia for lipids also. It is personal belief, it is more effective and best for us also. I shall skip this. ADA position statement of 2015 follows the same thing as far as utilization of statins are concerned. They goes with the ADA. So I conclude by saying that dyslipidemia is the neglected, common and dangerous. Simple, focused ACC guidelines are the best. Use the best drug in the proper dosage. Indians require and tolerate high dose of statins. ACC, AHA, ADA path is the best for dyslipidemia.
Thank you, Dr. Harish. Now I call upon Dr. Rajesh.